and cancer. Saddle up and wear some padding or something. Gotta protect that pudendal. Welcome to the Panama Canal. Completed in 1914 and expanded to now include 3 sets of locks. The canal is considered one of the greatest engineering achievements of the 20th century. Its locks work like water elevators to allow ships to pass through the canal in a stepwise progression. Crossing takes about 8 hours, but our trip will be much faster. The locks will represent the anal canal, with the top of our picture acting as the rectum and the bottom the anus. First, the anatomy. Remember that the pelvic diaphragm forms a constriction, or sling, between the 5-inch-long rectum and the 3-inch anal canal. The anal canal starts at the sling and ends with the anal verge, leading to the cold, unforgiving outside world. It's important to discuss that where the rectum meets the anal canal, there's a transition zone and watershed. This division is called the dentate, aka pectinate, aka anorectal line, aka rectum teeth. Okay, one of those is made up. I'll let you decide which one. This line forms where the endoderm meets the ectoderm, and it's where columnar mucosa meets squamous mucosa. Take a look. Above the dentate line, the canal is lined with columnar bricks, and below the dentate, you'll find squamous tile. The innervation above and below the pectinate differs as well. The region above the line is innervated by autonomic nerves from the inferior hypogastric plexus. That's autonomic, not somatic. This means that there is only sensation to stretch and not pain. See the yellow rope ladder leading up to that stomach-shaped tower? It's supposed to evoke an image of a nerve plexus underneath the stomach, and therefore the inferior hypogastric plexus. See what we did there? We've also installed an automatic sensor to emphasize that these are autonomic nerves. Any stretching caused by oversized ships entering the canal will automatically trip the alarm. All right, the region below the dentate line receives somatic innervation from the inferior rectal nerve, a branch of the pudendal nerve. So because it's somatic, way down in those nether regions, you can feel touch and pain. And when I say pudendal, I want you to think of this pudendal peddler, powering the innervation to the lower section of the canal. Feel the burn. Surprise! The vasculature and lymphatic supply differ above and below the dentate line as well. Above the line, venous return heads towards the portal circulation. See that Schooner's porthole? Venous blood travels through the superior rectal vein to the inferior mesenteric vein en route to the portal vein. That's International Marine Vessel for inferior mesenteric vein. What about below the dentate line? From there, veins drain from the inferior rectal vein on into the internal pudendal vein. So, because we've got yet another pudendal down here below the dentate line, we've drawn in another peddler, a pudendal paddleboat, if you will. This is systemic circulation, remember, so blood then drains into the iliac towards the inferior vena cava. So in summation, portal circulation above, systemic circulation below. All right, it's time to talk about hemorrhoids. Hemorrhoids are dilations of normal vascular structures in the submucosa of the anal canal. These plexuses of vessels contain arteriovenous channels, and they like to get all congested and bulge. Yeah, it's as annoying as it sounds. Hemorrhoids appear both above and below the dentate line, as depicted by the 2 sets of arteriovenous pipes at the top and bottom of the canal. These are defined as internal and external hemorrhoids, respectively. Internal hemorrhoids have autonomic innervation. Remember that inferior hypogastric nerve? So they don't hurt. They do bleed, however. The bleeding is classically painless bleeding. See what I mean? He's fine. The bleeding is usually seen during a bowel movement. The blood is often described as coating a stool or dripping after defecation. And if you take a close look at that schooner passing through, you'll notice some blood coating it, as well as some extra drippage. Painless bleeding can also occur with colon cancer, so keep that on your radar as well. External hemorrhoids, on the other hand, don't usually bleed, but they can hurt. Thrombosis of external hemorrhoids will cause acute onset pain. Superficial ulceration can also occur slowly, leading to pain. Ouchie. Remember, that pedaling pudendal guy is the one conveying sensory information below the dentate line. These are somatosensory fibers, so get ready for pain. Internal and external hemorrhoids are often seen in older patients and patients on chronic opioids because of opioid-induced chronic constipation and the increased intra-abdominal pressure from straining with defecation. All that straining. This guy needs to calm down. Hemorrhoids can also be seen in pregnancy from increased intra-abdominal pressure and IVC compression, leading to venous pooling and engorgement. Internal and external hemorrhoids communicate with each other and drain inferiorly, through that pudendal vein we talked about earlier and onward towards the vena cava. Remember the porthole up above, though? That's right. We now have direct communication with the portal venous system above the pectinate line and the systemic venous system down below. So imagine a bunch of pressure in the portal system. Portal hypertension, in other words. Yeah, blood is going to back up and make some serious hemorrhoids. This is a portal caval junction, remember. So extra venous blood from the high-pressure portal system is allowed to drain inferiorly to the low-pressure system of the internal pudendal vein up towards the inferior vena cava. A portal caval anastomosis, so to speak. Feeling a little uncomfortable? Wait till you see this next one. Time to talk about rectal prolapse. Rectal prolapse is a telescoping of the rectum through a weak pelvic floor and out of the anus. Hence the barge here, pushing right through that anal gate. Bet you've never heard that sentence before. And if you have, well, you must live an exciting life. Anyways, I'm telling you, rectal prolapse is just like a telescope, with the layers of mucosa folding on each other and popping right out there. Rectal prolapse is associated with older women and constipation. All that straining combined with the weak pelvic floor, plop. Having lots of previous vaginal deliveries or pelvic surgery doesn't help either. Rectal prolapse can also be seen in men and children. In children, it's seen with whooping cough, caused by increased intra-abdominal pressure during coughing fits. Rectal prolapse has historically been associated with the coughing and strained defecation episodes that go along with cystic fibrosis. However, this has become rare, likely because of childhood screening. But just for good measure, we've included a recurring sticky cystic fibrosis tree sap, falling on yet another coughing, straining, little huckleberry Finn kid. The top of the butt crack, or natal cleft, said no one ever, is a classic place to find an abscess. In this location, it's called a pilonidal abscess, or pilonidal sinus if it's open. They form because of stretching of the fold at the top of your booty crease. Opened and closed, eventually causes hair follicles to break down. Sometimes a pit can form. This pit collects debris and flora, progressing to infection and abscess. This is represented by this jungle plant here. That's kinda hair follicle-like. Not to mention pretty cheeky there at the bottom. I'm guessing there's an abscess down there. Yep, just rife with pus. On exam, a pilonidal abscess will be a painful sacrococcygeal mass that might be draining pus, usually on a 20-something-year-old patient. The first time, treatment is simple incision and drainage, so roll up your sleeves and start hacking away. Now let's turn our attention to fissures and fistulas. Anyone up for a ride on the anus? Yeah, this guy also immediately regretted the decision. Anal fissures come from a sphincter gone crazy. They start when something irritates the anus. So trauma, like a hard stool or a real bad diarrhea, vaginal delivery, or, as you can see here, dragging the anus like an inner tube over sharp rocks. Definitely some trauma there. Once it's stretched or torn, it overreacts and becomes spastic. See those spastic, shaky lines? This leads to even more stretching and tearing. It's a vicious cycle. 90% of cases of fissure are posterior near the midline. Posterior means towards the top of the butt, if your patient is standing. Many fissures have an anal tag marking their location. How convenient. The hats with flaps are meant to evoke an image of the flat skin tags that mark the fissure, also marking these guys as tourists. Fissures that are located anteriorly or laterally are much less common and should be considered suspicious for less benign processes, such as Crohn's disease, malignancy, or infection. So anteriorly, we've drawn in our usual patchy cobblestones, representing the cobblestoning and skip lesions characteristic of Crohn's disease. All right, moving on to fistulas. A fistula is an abnormal connection, or tunnel, between any two epithelialized structures. Fistulas often involve the bowel and an adjacent structure, like the anus, vagina, or even the skin. In this scene, the fistula runs from the anus or rectum straight to the skin surface. Generally, these tracts form when an anal rectal abscess drains both internally and out to the adjacent structure. Hence that abscess-like bulge in the center there. See the epithelial cell design we've incorporated into the pipe? A fistula isn't just a tunnel through tissue. Over time, the tract actually becomes epithelialized. Anal rectal fistulas, in particular, are also associated with pelvic radiation and Crohn's disease. In patients with Crohn's, transmural inflammation of the bowel leads to the formation of sinus tracts, which progress to fistulas. Remember, we have 2 red flags for Crohn's disease now, both anterior anal fissures and anal rectal fistulas. Symptoms of fistulas vary with location, but with anal rectal fistulas specifically, expect some purulent drainage, constant perianal pain, and pain with defecation. Lots of pain. Again, I want to remind you that we've got a lot of sensory input down here. You're probably looking at this sketch and saying to yourself, something's missing. Well, you're right. Crabs. Our recurring cancer crab, to be exact. There are 3 types of anal cancer, the majority of which are squamous cell carcinoma, and as such, show the classic keratinization seen with SCC elsewhere in the body. Those pearls of keratin are symbolized by the hermit crab's shiny, keratinized shells. When squamous carcinoma arises in the epithelial transition zone, closer to the dentate line that is, it is non-keratinized, also called basaloid. No keratin, no shell. See? Notice, too, that this little guy is right on that dentate line. Basaloid or non-keratinizing carcinomas make up about 25% of anal cancers. Rarely, adenocarcinoma can pop up in the rectum. That means we're up above the dentate line in the cuboidal epithelium. See? All crabby and glandy looking. This rectal adenocarcinoma behaves like colon adenocarcinoma. The big thing to remember here are that the risk factors for developing squamous cell carcinoma of the anus look more like the ones for genital cancers rather than GI cancers. Specifically, think of the risk factors for cervical cancer. HPV infection plays a big role, especially with high-risk types such as 16 and 18. So send in those papilloma pill bugs. HIV infection is another big one. Hence our recurring HIV white wizard hat. That's a callback to Sketchy Micro. Remember that retroviral wizard? Classic. And it's not just HIV infection. Other immunocompromised states contribute to a higher risk as well, including transplant patients and those on chronic steroid therapy. Just like in cervical cancer, even cigarette smoking is associated with anal cancer, most likely through a direct carcinogenic effect. Men who engage in homosexual sexual activity, especially receptive anal intercourse, are also at higher risk. Part of this has to do with increased exposure to HPV and HIV. And in both men and women, lots of sexual partners doesn't help either. And that's the way the anus crumbles. Time to sum up this sketch with a quick review of symptoms. About half the time, anal rectal cancer presents with bleeding. So let's add some more blood pooling around those 2 dudes doing the Panama Canal tonsil tango. Remember, if it's below the dentate line, it's going to be painful. This includes external hemorrhoids, anal fissures, pilonidal cysts, and anal rectal fistula. If they say, "Doc, I've got pain less bleeding," think of things above the dentate line, including internal hemorrhoids and colorectal cancer. That's a lot of info to cram into one anus. It's okay, just walk it off.